Welcome to the Pancreatic Cancer Action Network's webinar, Early Detection of Pancreatic Cancer. My name is Sheila Butt, and I'm the Senior Case Manager of HCP Services for the organization. At the Pancreatic Cancer Action Network, our goal is to give you comprehensive resources so you can make informed decisions. Patient Central can provide free, personalized information on many pancreatic cancer topics, including risk factors and surveillance programs. Contact Patient Central at 877-2-PanCAN or email patientcentral@pancan.org. I would also like to take this opportunity to thank our webinar sponsor, Ispen, and to thank our scientific and medical affairs industry members, Halozyme, Ispen, Janssen Oncology, TriSalus, and TYME. The webinar is scheduled for 60 minutes and includes a presentation followed by a Q&A session, time permitting. The questions that are relevant to today's topic and more general in nature will be prioritized. A recording of this presentation and the slides will be available under the Educational Events page at pancan.org. Now I would like to introduce our presenter. Dr. Suresh Chari is a professor of medicine with the Mayo Clinic College of Medicine. He is also a consultant in the Division of Gastroenterology. He is head of the Pancreas Interest Group in the Division of Gastroenterology and Hepatology, and also a member of PanCAN's Scientific and Medical Advisory Board. Dr. Chari has a broad interest in diseases of the pancreas, and his NIH-funded research focuses on the role of diabetes and hyperglycemia as a marker of undiagnosed pancreatic cancer. Additional areas of clinical research involve understanding the clinical spectrum of autoimmune pancreatitis, and he is also interested in cystic tumors of the pancreas. His current project, Pancreatic Cancer-Induced Diabetes, A Clue to Its Early Diagnosis, has a long-term programmatic goals to facilitate early detection of pancreatic cancer. Dr. Chari, I will now turn the presentation over to you.
Thanks, Sheila. Hello, everybody. As Sheila mentioned, I have a lifelong interest in early detection of pancreatic cancer, and what I will do today is go over what the issues are with early detection, what promise early detection holds for pancreatic cancer, and what are the prospects of being able to do this. So I have no specific conflicts of interest to disclose. I do want to acknowledge Dr. Ayush Sharma, who was a research fellow with me for the past couple of years, who's done some amazing work that will be presented here, which has made a significant inroads into understanding some of the clues to early diagnosis that we're going to talk about. A broad introduction to pancreatic cancer. In the United States, the lifetime risk of getting pancreatic cancer for any citizen is about 1.6%. It represents around 3.2% of all new cancers and is relatively uncommon as the 12th most common cancer. The annual incidence of pancreatic cancer in 2019 is going to be 56,770 Americans. On the survival side, it has a fairly dismal 5-year survival of 9%, and because of that, it's the third leading cause of cancer death after lung and colorectal. And unfortunately, it's set to become the second leading cause in just a decade after lung. And among the top lethal cancers, it's the only one that does not have an early detection strategy. So, what are the problems with early detection of pancreatic cancer? So let me briefly go over the natural progression of pancreatic cancer, and then we'll discuss what the issues are. Like most cancers, pancreatic cancer also starts as a tumor confined to the pancreatic duct. And somewhere below 10 millimeters in size, that's less about 1/3 of an inch, it becomes what is called invasive cancer. That means it invades into the pancreatic duct. And from then on, the rest of the stages are all invasive cancer. The small cancer, what is termed a small cancer, is less than 20 millimeters in size. And the average size of a tumor that's removed by surgery is around 30 millimeters in size. The problem is this entire spectrum of tumor sizes that are removed by surgery happen before symptoms occur. And at the time the person presents with symptoms, 85% are not removable by surgery. So let's go over the barriers to early detection and the implications for early detection. I'm talking about sporadic pancreatic cancer that is non-familiar, a person without a family history of pancreatic cancer. That's what 90% of pancreatic cancers are. They don't give you a family history. So it's an uncommon disease. As you saw, it's the 12th most common cancer. And so if you look at the incidence of pancreatic cancer in all subjects over the age of 50 in the United States population, it's around 38 per 100,000 people. And at this low rate, it's not possible to screen everybody for pancreatic cancer. It has to be restricted to high-risk groups with a high incidence of pancreatic cancer. That's the first hurdle. If you look at lung or colon, for example, you do screen everybody over the age of 50. Mammogram is everybody over the age of 40. In other major cancers, it's just age is the only cutoff. In lung, is of course smoking history has to be there to have a good yield. But in pancreatic cancer, you can't use age as a cutoff because the risk is not enough. The second major problem is that at the time symptoms occur, the disease is at an advanced stage, as we saw in the earlier figure. So detecting pancreatic cancer will require looking at subjects who don't have any symptoms. So now again, the question: who do you look for? In whom do you look for if there are no symptoms? The other problem is that it doesn't have a good biomarker for early detection. CA19-9 is the only one available, and it is stage sensitive. That means that the higher the stage, the better the sensitivity. So when you go back in time and look at smaller tumors, it tends to be less sensitive. So we are still on the lookout for alternative biomarkers for early disease. And at least based on studies done using somewhat older CT scanners, it appeared that detecting early pancreatic cancer using CT might not be a very sensitive way to look for cancer, and we may have to do more invasive testing like endoscopic ultrasound to find the cancer. We don't know what the high-resolution CT scans that are available today, what their sensitivity is, and there's an ongoing study that might answer that question. So if early detection was possible, what would be the promise of early detection? So before we go there, let's ask ourselves, what do you mean by early detection? At this point, our goal is modest. We want to pick it up before it is clinically diagnosed, that is, before symptoms occur. And if you ask why do the person come to the doctor for clinical attention, it's because of lack of appetite, that is anorexia, fatigue, weight loss, jaundice, abdominal pain, back pain. So these are the typical symptoms of pancreatic cancer, and we want to detect pancreatic cancer before these symptoms develop because our data suggests that these symptoms occur at a time when the disease is advanced. So early detection implies that we're going to interrupt the natural history of pancreatic cancer and move the clock back. So this is not an easy concept for us to sell because there is a feeling like this is snake oil. And so the question is this true hope or is this not possible? So the reason for the skepticism of early detection are two. One is it is even possible, and second is what if you detect it early? So the so what question. And the is it even possible question arises because if you look at the median survival after diagnosis is on average 6 months. So what are the chances that pancreatic cancer provides you a window of opportunity before diagnosis to make an early detection? If the progression after diagnosis is fast, why do you think there is an opportunity before diagnosis? So I'll go over briefly what happens to a cancer before its detection. And so the red arrow here points to the point at which the physician makes a diagnosis of cancer of a person who is presenting with symptoms. And the green arrow is when the cancer apparently started. And the blue arrow points to a point in the course of the disease at which a screening test available can detect the cancer. And the time between the blue and the red arrow is called the sojourn time of the cancer. And whenever the cancer is picked up, from that point on to the clinical diagnosis, that's called the lead time. And the question is, in pancreatic cancer, what is the sojourn time and what is the possible lead time for early detection? So a previous study tried to answer this question, and what they did was, the title of the paper is Time to Progression of Pancreatic Ductal Adenocarcinoma from Low to High Tumor Stages. And what they did was they took the entire database of cancers that's available in the SEER database and looked at the age of the patients in stage 1 and stage 2, stage 3, and stage 4, and other parameters, and basically found a 1-year difference between stage 1 and stage 4. And they concluded that once pancreatic ductal adenocarcinoma becomes detectable clinically, progression from low stage to advanced stage is rapid. So they felt like the lead time at the most was 1 year. We tried to answer this question a little differently. We know that pancreatic cancer causes high blood sugars, hyperglycemia, and diabetes. We have been working on this for 20 years, and there's a fair bit of evidence to show that pancreatic cancer elevates blood sugars. So we made an assumption that duration of this high glucose before diagnosis approximates the sojourn time of cancer, because after all, the cancer is causing the high glucose. So the duration of the high glucose would approximate how long the cancer has been there. So what we did was we live in Olmsted County. Mayo Clinic is situated in Olmsted County, Minnesota, and there is a unique data set here where all data, health-related data on all residents of Olmsted County is collected in one repository called the Rochester Epidemiology Project. And so between 2000 and 2015, we identified every single cancer that occurred in Olmsted County and found 2 controls for every case. And then we abstracted their blood sugars going back 5 years from the diagnosis of cancer and similar time frame for the controls. And we plotted the glucose in both groups. So the blue line here is cases of pancreatic cancer, and the controls are in red. And on the right-hand side, where it says 0 to -6, that is at diagnosis of pancreatic cancer, and you're going back 5 years in time every 6 months. And you see that these curves diverge at 30 to 36 months before the diagnosis of cancer. So that's the point at which the glucose is higher in pancreatic cancer compared to controls, and it keeps rising after that until it crosses the diabetes threshold around 9 months before diagnosis. So our conclusion from this study was that, yes, there is a window of opportunity, possibly up to 2 to 3 years before the diagnosis of cancer. So we should have time to be able to detect cancer earlier than we do it now. The next question is, will it make a difference? The so what question. And the issues that impact prognosis of pancreatic cancer, which are relevant at the current clinical diagnosis of cancer, how will early detection impact these factors that seem to limit the prognosis of pancreatic cancer? The first problem is that 50% of tumors at clinical diagnosis are at stage 4. And in these patients, treatment is limited to chemotherapy because they are not removed by surgery. Another 35% have vessel involvement that restricts surgical removal. With modern chemotherapy, some of these patients are being salvaged and being operated, but generally our understanding is 85% of pancreatic cancers are not removed by surgery. There is also this problem of poor performance status due to cachexia. Cachexia is a syndrome of decreased exercise tolerance, fatigue, and loss of appetite that precedes the diagnosis of pancreatic cancer by a few months. Most patients who have these pancreatic cancer diagnosis, if you ask them about exercise tolerance and fatigue and loss of appetite, they'll tell you, yeah, the last few weeks, the last few months, I've not been feeling as good, I've not been able to do as much, and I take naps. So this is problematic because it prevents the tolerance to maximal treatment, that is chemotherapy and surgery. And this happens in the last few months before diagnosis. And the other problem that plagues pancreatic cancer is that most scientists believe that the cancer has spread to other parts of the body, even though you can't see it at a smaller size, and they believe that this leads to it coming back with time. So how are these issues impacted by early detection? Because these are significant problems with pancreatic cancer. So we believe that detectable distant spread stage 4 disease and local unresectability, that is stage 3 disease, occur in the last few months before diagnosis. And how do we know that? We have gone back and looked at CT scans of patients who have had another CT scan for a different reason in the months to years before their diagnosis of pancreatic cancer. And we've gone back and looked at those scans, and we find that these unresectability and distant spread don't seem to happen more than 6 months before diagnosis. We think even less than that. It could be in the last 3 months. Same thing with poor performance status. Appears to occur in the last few weeks to months before diagnosis. And for this, we have some additional data. So what we did here was that we plotted the muscle area at one section on a CT scan in patients with pancreatic cancer who had serial CT scans before their diagnosis. They were being investigated or being followed for some other reason, so they had multiple CT scans. So we took advantage of those serial CT scans and looked at the muscle mass over time. And what we show here is that the muscle mass stays stable until 6 months before diagnosis, and it's only in the last 6 months that you lose muscle. And I would suspect that if you parse this even further, this might be more dramatic in the 3 months before diagnosis than in the 3 to 6 months before diagnosis. So we believe that the decrease in exercise tolerance, which is related to decrease in muscle mass, happens fairly close to diagnosis. So if you were to push the clock back, you would not see as much of this as you see now, which is a fairly prominent symptom in patients with pancreatic cancer. So stage shift, which is the decrease in stage of the tumor as we go back in time or as we detect it earlier, will provide a greater survival benefit than lead time. So lead time is, as we had talked about before, is the time between when you detect it by screening and when it might have been detected anyway clinically. So if you were to look at people who are early detected, they're expected to survive at least until they would have been detected clinically. So that's that difference is lead time. And there is always better survival in patients with early detected tumors because the lead time adds to their survival and makes it look better. But we believe that the benefit of early detection is going to go beyond lead time. And the reason for that is that survival in pancreatic cancer progressively improves with increasing therapy and lower stage. So as you have lower stage, you're able to offer the patients more therapeutic treatment, such as surgery and active chemotherapy. We also believe that the proportion of stage 1, 2 in the early detected tumors, even as little as 6 months before diagnosis, is going to be significantly higher than at diagnosis. Similarly, cachexia, or muscle loss, is going to be very uncommon at -6 months before diagnosis. And this will allow chemo and surgery to be taken by the patients, which will allow them to take maximal treatment and therefore give better survival. So one thing that we will not have an impact on is this undetected or inferred stage 4. That is, the biggest challenge to curing pancreatic cancer is to finding out where these tumors are hiding and why they're resistant to chemo and why it comes back. Our hope is that as early detection becomes the norm, that the scientific focus will shift on finding solutions to this problem, and together I think we can overcome. This is, in breast cancer now, there are numerous strategies to prevent cancer from coming back, and so there's no reason why we could not do the same for pancreatic cancer, if only we were shifting the focus away from just finding the tumor and removing it. So we believe this can also be impacted upon with early detection. So you see here that distant spread at diagnosis, that is stage 4 disease, stage 3 disease, and performance status, all can be impacted by early detection. And this undetectable distant spread, I think more efforts can be put into this if early detection becomes the norm. So you asked the question, okay, you convinced me that early detection will make a difference, and it's even possible, and there's a window of opportunity to do so, but how are we going to do it? And why now? And the reason for the why now is there is an opportunity to develop an early detection strategy for sporadic pancreatic cancer. When I started in this field, my colleagues would say it's not going to happen in my lifetime. So to see this happen now is really gratifying because we finally have an opportunity to develop an early detection strategy for sporadic pancreatic cancer. In the familial setting where there are multiple family members with pancreatic cancer, there has been an early detection strategy for a number of years, but for sporadic, there's been absolutely nothing. So it's nice to see that there is a progress in that field. So how do we envision this early detection happening? So we think there is this large group of subjects in the general population, and some clinical indicator is going to identify a high-risk group, higher than the general population, and we think this should be 6 to 8 times higher risk compared to the general population. And then there will be a strategy to enrich this high-risk group even further to make it very high-risk group. And here the risk is 25 to 50 times the baseline risk. And then we will use imaging techniques to find the lesion. So this is called the DEF strategy: define a high-risk group, enrich the high-risk group, and find the lesion. And eventually we'll have to biopsy it to confirm that what we are seeing is indeed pancreatic cancer. So this is our vision for how we will proceed with the early detection part. So we think that the clinical indicator is new onset diabetes. I'll talk to you briefly about what's called the NPAC score, which enriches patients with new onset diabetes for pancreatic cancer. Currently, we think a high-resolution CT or MRI can be used for imaging, and endoscopic ultrasound for biopsy in order to be able to develop an early detection strategy using existing tools. As we get more tools and as these tools get better, this strategy can only get better. So this whole initiative is being called the Early Detection Initiative for Pancreatic Cancer. It's an amazing partnership between the National Cancer Institute and Pancreatic Cancer Action Network, the Division of Cancer Prevention, and the Consortium for Study of Chronic Pancreatitis, Diabetes, and Pancreatic Cancer. And within that, the new onset diabetes cohort study. This is being funded by the NCI, and the Pancreatic Cancer Action Network will fund the rest of the strategy, which is the NPAC score validation and the actual screening using CT scan for early detection. So this is a very lovely partnership between the government and a Pancreatic Cancer Action Network to develop an early detection strategy for pancreatic cancer. So we'll discuss new onset diabetes is going to be the focus of that high-risk group, and we'll discuss why we have chosen that. So what we have done is in that subjects in Olmsted County in whom we could we identified 215 patients with pancreatic cancer in Olmsted County. And what we did was we typed their glucose status at diagnosis and tried to see what was the distribution. And we found that diabetes is very common. So about 55% of these patients have either new onset diabetes, which is defined as diabetes less than 3 years in duration, long-standing diabetes, which is more than 3 years in duration, and advanced pre-diabetes, that means it's pretty close to being diabetes, but it's just on the other side of the diagnostic criteria. Another 21% have an abnormal glucose, but they don't qualify for diabetes. And then there's only 9% of patients who have a normal glucose. There's a 15% unknown, so if you distribute that, this may be 10, 12%. But it's really uncommon to see a pancreatic cancer patient with normal glucose. Vast majority have an elevated glucose, and 22% had new onset diabetes. So it's a fairly large chunk of patients with pancreatic cancer. And as these strategies become more refined, they could be applied to other patients as well. So if you look at the risk of pancreatic cancer in diabetes, this graph here plots the risk versus the duration of diabetes. And you'll see that new onset diabetes, that is diabetes less than 1 year in duration, has nearly a 6 to 8-fold higher risk of pancreatic cancer. And it drops significantly once you get past that, and basically beyond 3 years, the risk is 1.5 fold, which is fairly baseline. But within new onset diabetes, the risk is 6 to 8-fold, and we have shown that if you take the first 3 years after the diabetes onset, about 1%, slightly less than 1% of patients will have a diagnosis of pancreatic cancer. This is in persons over the age of 50. So you have to develop diabetes for the first time over the age of 50. And this risk of 6 to 8-fold is similar to having 2 first-degree relatives with pancreatic cancer. But the difference is that this is a 3-year risk. That is, the diabetes risk is only in the next 3 years, whereas the family history is a lifetime risk. So the absolute risk in a given year is higher in diabetes compared to those with a family history. So how does this compare, this yield of 0.85% compare with other major cancers where screening is currently underway? In colon, the risk of finding colon cancer in a screened population is around 1%. In breast cancer over the age of 40 is about 1%. And in lung, it's 0.65%. So the new onset diabetes, 0.85%, falls in the ballpark of these other cancers in which screening is currently already mainstream. So it's not unreasonable to think that this should also be considered to be a possibility in terms of being subjects for early detection. So the question is, will new onset diabetes pick up cancer early? And I'll go back to that graph I showed you of the glucose in cases versus controls. I'll show you that the diabetes is happening around 9 months before diagnosis. And we believe anything beyond 3 months is going to benefit the patient, and certainly at 9 months it is going to be a significant benefit. So we believe that even at new onset diabetes, there will be a significant benefit to picking up the patients then. Of course, as you see in the graph, there is opportunity to go further back using criteria which are less than diabetes but are in advanced pre-diabetes area, and maybe we can make inroads into that as well as we develop this strategy further. So the question is, people have generally pushed back against 0.85% being sufficient for screening. And part of the reason is that this needs to be validated in another cohort. And though we have done it twice and both times we have got the same answer, we'd like to see it validated in another cohort. But there has always been a question of whether we could enrich this further and find a very high-risk group. So the very high-risk group is being defined as 25 to 50-fold higher risk than general population and has a 4% chance of having cancer compared to 0.85% with high-risk group, that is new onset diabetes. Now, if you take all long-standing diabetes, they have a 1.5-fold increase, and that's really small, 0.15%, and the average is 0.1. This is a 3-year chance of having pancreatic cancer. So the average person over the age of 50 has 0.1%, and the very high-risk group has a 4%. So the question is, can we get new onset diabetes enriched to a very high-risk group? So we developed a scoring system called Enriching New Onset Diabetes for Pancreatic Cancer Score that tries to do just that. And what we did was we used 3 factors that we thought were distinctly different between new onset diabetes associated with pancreatic cancer compared to the usual type 2 diabetes, which is the more common form of diabetes. One was people with pancreatic cancer were older. The second is the diabetes. You saw in that graph that the glucose rose much faster in patients with pancreatic cancer compared to controls. So we try to leverage that and say, okay, what is the change in blood glucose over the past year, and use that as a second factor that might discriminate between pancreatic cancer due to diabetes due to pancreatic cancer from type 2 diabetes. The other observation we have made is that unlike in type 2 diabetes, where the glucose rises as you gain weight, in pancreatic cancer, the glucose rises as you lose weight. So pancreatic cancer patients are losing weight even as their glucose is going up, which is completely paradoxical to what you would see in type 2 diabetes, where loss of weight is actually a treatment for type 2 diabetes and lowers blood sugar. So we use that also in our scoring system. So if you lost weight, your glucose rose up quickly, and you were older, your chances of having pancreatic cancer are significantly higher than those who met the type 2 diabetes profile. So what this graph shows is what the NPAC score does to new onset diabetes. So if you take new onset diabetes, the risk is around 0.85, 0.9%. You apply the NPAC score to this group, and now you get 3 groups. One group is a low-risk group, and this group has almost no risk of pancreatic cancer. It's 0.1%. It's very low risk. On the other hand, you have a very high-risk group, which has 3.6. That 4% mark is being reached here. And then there's an intermediate risk group that has a 0.5% risk. So we think that we can identify a very high-risk group and an intermediate risk group, or at least identify 50% of subjects as being type 2 diabetes and having minimal to no risk. So it has 2 advantages. One is it identifies half the patients as having no risk, and it identifies about 15% of the patients as having very high risk. So on both ends of the spectrum, it is of help in terms of risk stratifying patients with new onset diabetes. So now we think that we have the pieces in place that new onset diabetes would be our entry point. We would apply the NPAC score and enrich it, and then we would use CT scan to image these patients. And if they have an abnormality, we would clinically do the confirmation using biopsy. So that is the overall vision for how we would proceed further with early detection of pancreatic cancer in a sporadic setting. So our goal is to interrupt the natural history of pancreatic cancer, and this is a patient who had a CT scan for some other reason. He had a CT urogram. And this is the pancreas here, and there is a increase in size of the pancreatic duct, and that triggered the radiologist to bring it to our attention that this person had an abnormality in the pancreas. No mass was seen. The patient had no symptoms, but it led to an endoscopic ultrasound and found a small mass that was removed. So this is what we want to achieve deliberately, not by chance, but deliberately, and be able to detect pancreatic cancer early so we can offer them more aggressive therapy in terms of surgery and chemoradiation and be able to improve survival. Now, I'm going to stop here. I'll acknowledge the funding sources, which, of course, over the course of years, we have had NIH funding and continue to have NIH funding. But over the course of years, the Luscotton Foundation, the Kenner Family Research Fund, the Pancreatic Cancer Action Network, and a local benefactor have funded our research. And I must acknowledge the NOD team, which is the New Onset Diabetes team that has been working on this for years. Gloria Peterson and the Mayo collaborators helped us with the work that we have been doing for the last couple of decades. And then Barbara Kenner and Bill Go came along and supported an idea for a pilot screening study when it was not at all mainstream. This was many years ago. And that allowed us to actually pilot a screening study similar to what I discussed here, and now it's going national. So they gave us money well before anybody thought it was worth investing in. The national study that we're currently doing, the NIH is obviously supporting this one, but PanCAN has a very, very important role to play. Without their support, this will not get to a point where we are now of developing a actual practical screening strategy for pancreatic cancer. So greatly appreciative of PanCAN's efforts in every which way. But in this particular case, the early detection initiative is being driven by their work. So I'll stop there and take questions. Thank you.
Thank you, Dr. Chari, for that very informative presentation. At this time, we do have time for questions. So to start off, we had a few questions about surveillance and genetic testing. For individuals who have a family history, do you have recommendations for next steps?
So I think the Mayo Clinic recently published a major study in the Journal of the American Medical Association showing that all patients with pancreatic cancer would benefit from genetic screening. And those found to carry a mutation obviously fall into a high-risk group. And there are surveillance strategies for early detection there. There are different set of problems that affect surveillance in the family history situation, because pancreas is not normal in a vast majority of those patients, regardless of whether they get cancer or not, and that makes it harder to find the lesion. So at this point, I think the strategy for early detection there, the high-risk group is the people with two first-degree relatives. The family history is the first group, and then the two first-degree relatives makes it high risk, and then they're doing endoscopic ultrasound and MRI to find the lesion. And so I think that those who have carrying a mutation, that may be but it should be done under research setting still, because there are still many unanswered questions of who should go to surgery, what kind of surgery should they have. And so it may be best to be done in major centers with research interests so that we can collect the data and be able to find some answers to these questions.
Thank you. The next question is, what can we learn from screening programs for other cancers that would be useful for pancreatic cancer screening?
Very much so. So in our first early detection initiative kickoff meeting, we had people from other cancers that were there, and they brought up a number of issues that they had experienced. An interesting fact here is that in all other cancers that have an early detection strategy, the NIH was not involved at the development stages of the strategy. And this is the first cancer in which NIH is there right from the very beginning. And they did bring up a number of issues that are plaguing other early detection strategies and trying to make sure that we avoided those pitfalls. Some of them are overdiagnosis. That means and in the pancreas, that is going to be problematic. If you overdiagnose and actually do surgery, then you will actually maybe hurt patients who don't have disease. So we are learning from that. And so they have actually made us do a lot of things that we would otherwise not have considered, but I think that to make this idea mainstream and acceptable to everybody, we are actually following their recommendations in terms of many of the issues they brought up that are coming up in other cancers, and we would not necessarily have thought of as problems in our field. So,
Thank you. What early detection strategy do you believe will have the most immediate clinical utility for pancreatic cancer? So that could include a liquid biopsy, molecular imaging, et cetera.
So I think the problem with just using a biomarker is that by itself is not going to be sufficient, because the biomarker has to be in the context of a high-risk group. Because even if you take a biomarker that is 99% sensitive and 99% specific and apply it to the general population, for every positive cancer you find, there'll be 1,000 false positives. So it's just not feasible to apply only a test to the general population, even if it is over the age of 50 or whatever age cutoff you use. So all of these biomarkers that we're talking about, whether it's liquid biopsy or anything, has to be applied in the context of a group that is already at higher risk. If the pretest probability is not very high, then the test is probably false positive. So we are trying to identify high-risk groups in which these strategies can be applied. So new onset diabetes happens to be the first one, but there is also a possibility of taking subjects with long-standing diabetes who suddenly experience worsening of diabetes and seeing if that is a high-risk group. Unfortunately, worsening of diabetes is normal, happens normally in the course of type 2 diabetes. So how do you differentiate that from that induced by pancreatic cancer? So that's something that we are working on. But there are other high-risk groups that we will identify that will allow these other tests to be applied to. We recently published a paper where we actually found that a biopsy of the subcutaneous fat under the skin and the abdomen, carried a message which differentiated weight loss due to pancreatic cancer from other forms of weight loss. So there is a form of weight loss that happens in pancreatic cancer which starts 18 months before diagnosis. And that period, which is well before the clinical diagnosis, the patient actually feels well. They actually pat themselves on the back for having lost weight because it actually feels like normal weight loss. But we showed that this weight loss is due to a different mechanism and has a biomarker. And so we are slowly working towards finding other groups that might benefit from early detection strategies. But what we have the most data on is new onset diabetes, and that's why we are embarking on that path right now.
Thank you for that answer. The next question is, how can one find early detection and surveillance programs? Who should they be contacting for that information?
PanCAN.
Perfect. Thank you. The next question is, CA19-9, the tumor marker test, has been around for a long time. How come it's been so hard to find another quality marker, and do you see that being found on the near horizon?
Yeah, so if you look at breast cancer, how much money has been spent on breast cancer, and we don't have a serologic blood marker for breast cancer, not for lung cancer, not for prostate cancer as a PSA, which is also has a lot of problems. So finding blood-based biomarkers has not been easy, even in cancers that are common, and a lot of effort has gone into finding one. I'm not surprised that we don't have one for pancreatic cancer, but that doesn't mean that in future we will not, because just looking for protein biomarkers might have been the problem. If you look at molecular markers in DNA and other methods of using other tissues or other approaches to biomarker discovery, we may have a better success than simply looking at protein biomarkers. So, yeah, it's not very different from other cancers, but at the same time, there is hope that novel technologies will identify markers that are useful.
Thank you. The next question, kind of taking a shift over to early onset diabetes, are there any guidelines for surveillance for patients who have been diagnosed with early onset diabetes?
I would say that it is still in the research setting because we may say that if you have elevated diabetes in the face of weight loss, you should be suspecting it, but we would like to confirm this in a way that is applicable practically. And we are hoping that in the next 2 to 3 years, we will actually have data that will be clinically translated and can be done. So the new onset diabetes that we are talking about is not something that physicians diagnose, because physicians' diagnosis of diabetes, they lags behind the biochemical onset of diabetes by months to years. And because physicians often see an elevated glucose and tell patients to go home and lose weight, come back in 6 months, and by then time has passed. So we actually have been concentrating on the lab data and not on physician diagnosis. Because the early stages of diabetes are reversible, physicians often don't want to give the patient that label and give them an opportunity to lose weight and change their diabetes status. But for us, that first elevation of glucose and the first evidence that there is diabetes is what we are looking for, because we want to go back in time. So all these things need to be confirmed, and so I'm not yet ready to say that everybody with new onset diabetes should be screened. So just to become a public health policy, we will have to generate a bit more data. Yeah.
Thank you. There were a few clarification questions regarding new onset diabetes. So are hyperglycemia and new onset diabetes potential early indicators for pancreatic cancer in those only over 50 years old, or can they also be used for those under 50?
So for people below 50, the baseline risk of pancreatic cancer is significantly lower. Even 50 to 55, 58, it's lower than. It's age-related. So the lower you go, the lower the yield of pancreatic cancer. So you're now looking at a very low-risk group. And so so that's why we use the 50 cutoff. Some people have said you should use the 60 cutoff, but then you lose about 12% of pancreatic cancers in there. So I think 50 is a compromise between the extremes there. As far as hyperglycemia versus diabetes, again, same thing there. The lower you go with the glucose or the A1C numbers, more pancreatic cancers you'll capture, but more of the general population you'll capture. So it gets diluted. We looked at the risk so 126 fasting glucose is considered diabetes if it is persistently elevated above 126. So we looked at 126, 120, 115, 110, And we try to ask the question, if you newly develop 110, I mean, all of them have to be confirmed. That means you have to have two values above that consecutively. 110, 115, and the risk dropped 0.85, 0.65, 0.45, and then 0.3. So the lower the blood sugar level you want to use for your cutoff, more diluted the population will be for pancreatic cancer. Now your enrichment strategies will not get you very far. So at this point, we are focusing on diabetes, maybe advanced prediabetes, but not going any further without a clear way to enrich that population.
Thank you for that answer. The next question is, are there any studies looking at metformin prophylaxis in high-risk persons prior to diagnosis of onset diabetes?
Yeah, it's a good question. I think metformin, when it was initially shown to be anti-cancer, has been tried in a variety of cancers. But the problem with pancreatic cancer is that data may be flawed. What pancreatic cancer does is cause insulin resistance and cause your glucose to go up, or if you already have diabetes, your diabetes to go out of control. So metformin is often not helpful in these settings, and so you switch to insulin. So it looks as if metformin is protective because it's more often used in patients without pancreatic cancer than with, and so it may be what is called a protopathologic bias. It's the way the treatment is altered by the disease itself that seems to suggest that the drug is protective or causing cancer. So insulin got bad rep saying insulin causes pancreatic cancer. But that's because insulin is getting used close to the diagnosis of pancreatic cancer because the diabetes is not under good control. So it appears that insulin is causing pancreatic cancer, whereas insulin is just an indicator of the diabetes being difficult to treat, and therefore it seems to it's used more often. So metformin's role in prevention of pancreatic cancer is going to be, or progression, is not going to be easy to prove. At this time, the data is not sufficient to suggest that.
Thank you. The next question, taking another sort of slight direction change, is in the studies that have been conducted to discern a protocol for early screening, to what extent are the subjects of diverse races and ethnicities? How relevant and helpful would such diversity be for reaching the highest risk patients?
Absolutely. I think that African Americans have a higher risk, and we have actually been partnering with a group in UCLA that has a multi-ethnic cohort that has a large population of subjects with different ethnicities, actually non-white ethnicities, that they have collected. And we are looking at the risk of pancreatic cancer in that group, new onset diabetes in that group, and we are very much aware that all ethnicities need to be included in these studies. And much of our patients are going to come from dense urban areas where there is a lot of heterogeneity in the racial mix. So we hope to get a good mix of people in our studies that would allow us to answer these questions.
Great, thank you for that. The next question is related to cysts and how often cysts and lesions should be monitored, and what specific tests would be used, such as a cholangiogram or any other sort of insight that you can provide.
Yeah, so cystic lesions in the pancreas is a completely different area of study. Cysts are very common in the population. In the Medicare age group, 25% of people will have a cyst in the pancreas. So you are looking at a very low-risk group to start with. And now you have to find a high-risk group within that, and we have some data to suggest that there are certain cyst characteristics that put them at what is called worrisome category, and then there are high-risk categories. So there is already a risk stratification of cysts there. And our approach to surveillance of cysts is based on the risk category they fall in, the interval surveillance, and the type of surveillance is based on the risk category. And I use MRCP because they get repeated scanning, and CT scan gives radiation, so we tend to avoid that in patients who are going to get repeatedly scanned. So MRCP, but the interval of surveillance will depend on the risk category. And then if there is something which is suspicious, then do an endoscopic ultrasound to further evaluate that abnormality. So, but cysts and these are cysts, family history, and new onset diabetes. These are all different high-risk groups, and different strategies are used for early detection in these places.
Thank you, Dr. Chari. And we have time for one more question, and it's two parts here. So you mentioned weight loss and a rise in glucose is common. Is this specific to pancreatic cancer, or can this be caused by other factors? And if your blood sugar starts rising, should you seek testing for pancreatic cancer?
So the second question, I would say wait for the results of the study to be completed in order to know what the yield of that is going to be. But as far as other cancers are concerned, we have shown that new onset diabetes is unique to pancreatic cancer. We have looked at prostate, breast, colon, lung, and it's not found in those cancers. As far as the weight loss going back in time, I'm not sure how many other cancers have been studied in the same way that we have studied pancreatic cancer, but I suspect that it's again unique to pancreatic cancer. The reason I say that is that the weight loss going back 18 months is closely tied to rising glucose. And if you don't see rising glucose in lung cancer or breast cancer going back 18 months, I suspect you won't see the weight loss. But the weight loss part has not been that extensively studied in other cancers, but the new onset diabetes is not common and not a feature of any other cancer.
Perfect. Thank you again. We would like to thank Dr. Chari for his presentation. The PowerPoint slides and a recording of this webinar will be available at pancan.org under the Educational Events page. There may be a delay of several days before the information is posted, and your patience is appreciated. Once again, we would also like to thank our webinar sponsors, Ispen, and our scientific and medical affairs industry members, Halozyme, Ispen, Janssen Oncology, TriSalus, and TYME. A survey will pop up once you leave the session today, so please take a moment to share your feedback. If you have any questions, please contact Patient Central at 877-2-PanCAN and ask to speak with an associate. This concludes the webinar. Thank you.